Positioning. Now, tomorrow, I think we're going to hear from the OTs and physio around the relationship between Mealtimes and positioning. So I won't talk too much about it right now, but I guess I just wanted to emphasise the importance of appropriate individualised positioning. We know that good positioning contributes to a positive mealtime experience, and the main difficulty I often encounter when working with my clients is that despite recommendations, people are not repositioned before their meal. So they start their mealtime experience slid down in their wheelchair or fallen across to the side. Looking at energy and effort. So if a person is using all their energy to maintain a position, to fight against gravity to try to stay up, or if they're using their hands for support to keep their balance, it's going to be more difficult to focus or concentrate on their mealtime or swallowing safely. Their cognitive load is increased. Now, physios often talk about 24-hour positioning, but I think we probably need to talk a little bit about 24-hour swallowing. Now, I said at the beginning that swallowing is more than just mealtimes. Positioning for meals is really important, but positioning for saliva management at other times of the day is also really important. So how does the person manage their foods, fluids, medication secretions throughout the day and also throughout the night? I think it's easy for us to think about breakfast, lunch and dinner. It's not so common for us to think about saliva management and sleep positioning, or saliva management when someone's in a hoist or on a hammock or in the pool or lying on their change table. The physio I work with, Judith, and we often have lengthy discussions over positioning versus swallowing compromise. How can we each achieve the best outcome for our clients? And I guess if we look at our issues separately, we could both come up with really great solutions. I say, sit upright, great, swallow safely, no worries. And she goes, oh, it doesn't really work for the way that person's body is. And so that's why we need to look at this person quite holistically. And it's a lot more difficult, but a lot more important. We've both been working with a particular client now for a while who has complex positioning needs, but also complex swallowing needs. And I know that the more upright this particular person is, the safer he is to swallow. Judith, the physio, knows that this man's hamstrings are so tight that they pull his legs backwards, which means we can't actually position his hips at 90 degrees. So to put him in a more upright position, we're essentially placing him on a slippery dip. He'll slide right out of his wheelchair. So this particular client is a work in progress, but with each new wheelchair adaptation or change, or we keep assessing his positioning and his swallowing and make our recommendations based on the best option out of a couple of not ideal options. So having a look at how aware a person is positioned during, after and before their meals is also really important. How comfortable they look. How would you know if they weren't comfortable? It's really important as well to have a bit of a look at positioning equipment that people use around mealtimes. Now, I'm not suggesting that we work beyond our scope of practice, but it's still important to have a look at what they're using and whether that equipment is or isn't working for them. Important to look beyond the meal itself, so before and after. I recently went to see a client at home. Gary, he's in his mid-50s and his parents who he lives with are in their late 80s. I watched Gary eating dinner and there were no major issues around that, but immediately after dinner, Gary went to sit on the family lounge chair. Now, Gary's not particularly tall and the seat depth of the lounge chair is quite large, so for Gary to sit on the lounge, he sort of rounds his back and leans back and tries to rest his head on the headrest. He kind of tips his pelvis in a funny way and puts a bit of extra pressure on his stomach. And when he's in this position on the lounge, he struggles to breathe and he has a bit of a weak, half-hearted attempt at a cough. And he often sits on the lounge to have a drink after dinner, and that's, I think, where we're having the problems with his chest infections at the moment. So I guess thinking about seating and positioning, assessing that it's not really our area, but making observations and consulting with the physio or OT around positioning in safe swallowing is part of our area, that is part of our role. So just another little piece of the puzzle that we need to put together to come up with a holistic view of the person around mealtimes. from. Weight and nutrition. So similarly to other health conditions, there's a higher prevalence of weight and nutrition issues for people with intellectual disability than with the general population. We know that a person's energy intake will determine their body weight. So typically if a person eats more than they need, they'll put on weight. If they eat less than they need, they will lose weight. Thinking about underweight, so we know that underweight can be a risk factor for dysphagia, but we also know that if someone has difficulty swallowing, it makes sense that they're not actually consuming enough food or calories to meet their nutritional needs, so then they would be underweight. Looking at overweight, it's been really well documented in the literature that people with intellectual disability are significantly more likely to present with overweight status and obesity from childhood all the way through to adulthood. And interestingly, women tend to present with more overweight status than men in people with intellectual disability, and men conversely are more likely to be underweight than women. And I guess the other thing to look at is about nutrition. So people with intellectual disability in developed countries, the research looks at the fact that there is insufficient nutrition knowledge, limited food preparation skills, and diets that are high in fat and calories, and low consumption of fruit and vegetables for these people with intellectual disability. And these can lead to poor food choices and potential other health issues. And I guess the other thing to think about is when you're malnourished, people present with decreased energy levels, decreased cognition, which can then impact on alertness, so they're unable to eat safely, and that makes us, causes further dysphagia, and it becomes a bit of a cycle. The big thing I think here around weight and nutrition is that it's really important not to work outside our scope of practice. Consult with a dietitian. They know so much. I know that sometimes general information around food and nutrition can seem really simple, but there are so many added complexities that speech pathologists aren't as well trained to address. I'm really lucky in that I can work collaboratively with a fantastic dietitian, Karen, at our local base hospital. She's really supportive of people with intellectual disability. She's always open to answering my questions, and I have a lot. And we often work together to provide consistent, practical recommendations that meet both the person's nutritional needs and their texture modification prescription. So if you can find a good dietitian, just hold on to them really tightly. Weight and nutrition, again, some of the big things to think about. Medication. What medications is a client on that might have side effects of overweight or underweight? And think about other things as well, like unintentional movement. So someone who might have atherosclerotic cerebral palsy, constantly moving or constant tight muscles, how might that impact weight gain or weight maintenance? Now, I also work a lot with clients with fluctuating presentation, usually due to neurological issues, and that means that some days they can eat and drink really well, really effectively, and other days they can't eat and drink safely at all. So consulting with the dietitian around how to increase calorie intake when the person can eat and drink safely is another really important thing to consider. We've got our barriers and solutions, and I'll just keep skipping. Respiration. So in the Ombudsman report written last year, which focuses on deaths of people with intellectual disability in residential care, it identified that respiratory disease is the overall leading cause of death in 2012 to 2013. And so compared to the previous report, a higher proportion of people died from community-acquired pneumonia, aspiration pneumonia, and choking or asphyxiation. There's been a bit of research done by Chadwick and Jolie, which identified that 40% of adults with intellectual disability experience recurrent chest infections, which is a bit of a problem if you ask me. We know there are lots of risk factors for death-related respiratory illness, including mealtime dependence, which we mentioned before, problems with swallowing, eating and mobility, some conditions such as epilepsy, cerebral palsy, Down syndrome, gastrointestinal problems like reflux. It's also really important to consider how a person's positioning can impact their respiration, and in turn how that can impact their swallow. So we need to think about some postural fixed deformities, scoliosis, kyphosis, independent head control. I was working with a baby recently who had cerebral palsy at GMFCS level 5, so gross motor function classification system level 5, that's the most severe, and that meant that this little boy didn't have the ability to hold his head up independently. So the physio and I worked together to balance appropriate and safe positioning for development, considering airway compromise, and to ensure safe swallowing of saliva throughout the day. And I guess a lot of the time with the clients that we tend to work with, it ends up being a conversation about compromise. So a compromise between the positioning, the respiration, and the swallowing, amongst other things sometimes as well. So having a little bit of a think about a person's chest health history, that can give you a good picture of what might come up in the future. Are they on permanent antibiotics? Is that why they haven't had a chest infection? Because they're already being treated for it. Any changes in respiration throughout the meal, with different seating positions, with different movements in different places? How deep or shallow is the person breathing? Is this typical for the person? Does their work of breathing change throughout the meal, after the meal, in their bed, when they're relaxed, when they're excited? Is the person's breathing regular and coordinated, or a little bit more chaotic? There's a whole bunch of things to think about with our breathing. So, moving on to oral health. People with intellectual disability, again, present with more oral care problems more frequently than the general population, and historically oral care has been a neglected area of health for people with intellectual disability. So in general, studies suggest that an association between poor oral hygiene and respiratory pathogens. It suggests that there is a decrease in the incidence of respiratory complications when patients are provided with intervention around oral care, and it suggests that the complex nature of periodontal disease and aspiration pneumonia makes it really difficult to determine which comes first or what's going on. And it's really important to reduce the incidence of aspiration pneumonia by addressing that through oral health care. Now, we know that poor oral health can impact quality of life, so eating, drinking, pain, breathing, sleeping, self-esteem, and it's really important that we have a bit of a look into someone's mouth to see what their teeth and mouth look like, because we might be the only people that do get to have a good look in their mouth. So it's really important to document and refer to a dentist if you can, or if that's needed. Now, often people with intellectual disability wait until they go under general anaesthetic before accessing dental care. But just because someone has an intellectual disability doesn't mean that they need to be precluded from regular dental checkups or procedures or support. So have a bit of a think as well about the oral hygiene bolus. That's another thing that I've been thinking about lately. How does the person manage toothpaste, mouthwash, excess saliva around brushing teeth? Can they spit? Do they swallow what's in their mouth? Do they swallow safely? Just a few other bits and pieces to consider. And I guess the other thing is that the SPA dysphagia guidelines recommends that oral hygiene is incorporated into our dysphagia intervention because of those really important links between oral health and aspiration. So we're looking in someone's mouth. Which teeth are present? Which teeth are absent? Map the teeth. How might missing or decaying teeth impact someone's biting or chewing or behaviour around mealtimes? And I know sometimes it can be really hard to see in someone's mouth, but it's really important to be creative. So I was working with this woman who I could not for the life of me get to open her mouth. She sat in front of me with her arms crossed and her lips closed. There was no way that was going to happen. But from talking to her support worker, we found out that she really loves to sing. 80s ballads, apparently. So we put on some music that she enjoyed and started singing together, and that really allowed me to get a good look inside her mouth when she was belting out those notes. It allowed her to have a great laugh at my expense when she realised I'm probably not going to win the voice, but it was a really good way to have a bit more of a look inside her mouth. The other thing we need to think about is about recommending oral care following meals and the practical implications that might have when someone's out in the community. So often the clients that we work with, they attend school, they attend day placement, they might have lunch in the park or at the cafe or at the pool. How do we encourage really good oral hygiene following meals in these places? So a proper, teeth clean might be an option if you're out in public, but unlikely. Or it might just be about, using a damp face washer or something to wipe away any oral residue. Our barriers and solutions. I really think that one of the big solutions for oral health is to consult with a dentist, but also acknowledge that sometimes dentists can be a little bit scary. And often I found that sometimes the support workers are a little bit more fearful of the dentist visit than the person they're supporting. So I guess it's about considering how we support those dental visits. So social scripts, video modelling, rewards charts. It comes back to the idea that swallowing isn't just an isolated issue, and maybe we need to consider some communication support around this to make a bit more of a difference. Okay, saliva management. So there are 3 major pairs of saliva glands in the mouth, submandibular, sublingual, parotid, and it's estimated that between 500 mils to 2,000 mils, so 2 litres of saliva is produced in the mouth per day. We need saliva. It's really important. It lubricates our food to assist with chewing and turning our food into a bolus. It lubricates the tongue and lips during speech. It cleanses our teeth and gums to assist with oral hygiene. It regulates the acidity in our esophagus, and it facilitates taste as well. We know that people with immature swallowing patterns, for example, a tongue thrust swallow, they're more likely to present with saliva management difficulties. And this could be overproduction or underproduction of saliva, but more likely it's a difficulty keeping the saliva in your mouth or difficulty swallowing your saliva safely. So I guess one of the main differences or things to think about between swallowing saliva or swallowing food is the decreased anticipation of your swallow and decreased sensation as well. So if you think about, you pick up a piece of chocolate and you're holding it, you bring it to your lips, you've smelt it, you put it in your mouth, you move it around, you taste it, you swallow. Great. Saliva's already there. You're not picking it up, I hope. It's already in your mouth, you're not moving it around, you just swallow as you swallow. So we've got that decreased level of anticipation around that. We know that changes in saliva production can indicate neurological changes. So I told you about Gary before, the man living at home with his parents and slouching on the couch. One of the reasons he was referred was because he's had more difficulty lately managing saliva out of one side of his mouth, and he's going through more hankies than he used to. And that's how they identified that that was a bit of an issue. So saliva management, something we need to consider throughout the day, not just at mealtimes. So recently, our team was referred a woman for a sleep assessment, mainly for physio, and the physio I work with is really collaborative, so she immediately got the OT and I involved. This woman had only ever laid on one side at night to sleep. She's presenting with a pressure area on her hip and also on her ear, and she had this odd rash as well, kind of over her eye and her cheek, and we kind of worked out that one of the big issues here was that she was having difficulty managing her saliva. So she was drooling throughout the night, sleeping on a wet pillow, which in turn was irritating her ear and her cheek and her skin. So I guess, thinking about swallowing, saliva management across the day, it's complex, it's multifaceted. So the other thing I guess to consider is around how much your saliva production or saliva management difficulties impacts a person and their family. So does the saliva smell? Is it causing skin irritation? Is it contributing to embarrassment? I've worked with families where the older sister of a child who drools a lot doesn't want to go out in public with him. But I've also worked with people who say, oh, it's fine, don't worry about it. I just use my hanky and wipe it away. Nothing to worry about. Sometimes it can be really difficult to get support workers or family members to identify saliva control difficulties. So it was probably a few months ago now, I was talking on the phone with a support worker about a client swallowing, and I brought up the topic of saliva. And the support worker said, "Oh no, that's not a problem, not an issue for Craig." And I thought, perfect. So I asked, so he doesn't have any sort of saliva fall out of his mouth when he's sitting on the lounge? Oh, no. And he doesn't wear a bib or a neck scarf or anything? No. And he doesn't wipe his mouth with a hanky? Nope, none of that, he's fine. Although sometimes, and I was like, oh yeah, actually sometimes he can be walking across the floorboards in the living room and he drools so much that he slips on the saliva that's on the floor. And I was lucky I was on the phone, or this guy would have seen my eyes pop out of my head and my jaw hit the floor, and went, "That's not just Craig." Like, he kind of said, "Oh, but that's just Craig, that's what he does." I said, "No, it's a bit of a risk to him and for hygiene and for everyone else walking in that area." So I guess it's about asking the right questions then, about figuring out how that saliva management can impact in a variety of areas across the day. Okay, gastro. So again, we know lots of people with intellectual disability present with gastrointestinal issues more frequently than the general population. And I guess some examples of common GI issues for people with intellectual disability are esophagitis, reflux, regurgitation and rumination, Helicobacter, constipation, diarrhea. Predisposing factors of reflux include scoliosis or cerebral palsy or anti-epileptic drugs. And a lot of researchers speculate that despite the already documented high rate of people with intellectual disability and reflux, it still remains an underdiagnosed condition for people with intellectual disability. Reflux is a big problem for people in this population, and not just for people who eat and drink orally, but also people who are enterally fed. So not long ago, I was working with a woman who has been fed through a gastrostomy for about 10 years. Heather, she was taking some medication to manage her saliva, and mostly things were okay. But over the past summer, she'd had 3 chest infections and subsequent diagnoses of aspiration pneumonia. Now, when we reviewed when these chest infections began, it was when a nurse recommended that she start taking each of her medications crushed individually with a water flush in between enterally. And my understanding is that in general, this is best practice for how you would take enteral medications. But for this particular woman, it meant having a really large bolus in one go in the morning and in the evening. And so we had a bit of a think and hypothesised that maybe she wasn't tolerating these really large bolus feeds and was possibly presenting with reflux because she had a history of this, and perhaps even aspirating on that reflux. And so when we worked with the GP to change her medication regime just back to its previous state, her chest infections stopped. And I guess this example, apart from identifying that reflux can be a big issue, is about having a little bit of a think about that evidence-based practice diagram from the beginning. So yeah, the research evidence is important, but it's also important to consider the client's current circumstances and information from the context to figure out what's going on for this particular person. Now, I'm not going to go through all of these gastro issues, but I think the important part here is about recognising the prevalence of gastrointestinal issues for this population, and also recognising that sometimes when people present with behaviours of concern, the underlying cause or issue may actually be a physical health issue like reflux or constipation. So a couple of things to think about: what gastro issues might be impacting a person's mealtime experience, and what might that look like. I think a lot of the time people have complex communication needs, so they can't tell you, but here are just a couple of examples of what they might look like. So reflux, you might be rubbing at your chest, chewing on your hands, excess burping, loss of appetite, and dental erosion as well. Constipation, food refusal, maybe the person hasn't been drinking as much water lately, maybe they're hunched over. Helicobacter can be asymptomatic, so that's not very helpful at all. But I guess just thinking about the fact that that could be a related issue when you're working with this client group.